Hello, welcome to FISPGHAN Expert Insights. I'm Pornthep Tanphapong from Bangkok, Thailand. Today, Professor Hania Szajewska from Poland is here with us to talk about probiotics. Good afternoon, Professor Hania.
Good afternoon. Pleasure to be with you. Thanks for the invitation.
Let's start with a good practical question first. Which indications have the strongest evidence for probiotic use? So please give us the top three for clinical indications in pediatrics.
This is an excellent question and being asked every now and then. And if you ask me to choose the three best documented indications, so I would say I will start probably with the prevention of antibiotic-associated diarrhea. And what is important that we do not talk about probiotics in general, but we always specify which probiotic strain are effective. And for prevention of antibiotic-associated diarrhea, typically two strains appear, and this is L. rhamnosus GG and Saccharomyces boulardii. So this is the first well-documented indication for the use of probiotics with documented efficacy. The second one, I would say acute gastroenteritis, management of acute gastroenteritis. And here again, the same two strains are usually listed, L. rhamnosus GG, Saccharomyces boulardii, but also L. reuteri DSM 17938, and more evidence is on the efficacy of that particular strain. And the third indication, as you asked me to choose only three, now I hesitate, but I think in real life, for practical reasons, I would say management of infantile colic. Management of infantile colic, and at least in our FISPGHAN guidelines, we do have two strains, and these are L. reuteri DSM 17938 and Bifidobacterium lactis BB12. And all these letters and all these numbers, which are next to the name of the microorganism, are extremely important because not all strains are equal, and it's always important to know which particular strain we are discussing. So these are my subjectively chosen three best documented indications.
Okay, so AAD, acute gastroenteritis, and infantile colic. Okay, so let's talk about antibiotic-associated diarrhea. I think as pediatricians, we get this quite often. Is when and how long that the probiotics should be given in the course of antibiotics, or should you give even beyond the course of antibiotics?
Yeah, this is truly one of those frequently asked questions. So when should probiotics start? And as early as possible. So the moment you start administering antibiotics, then you should also think about starting probiotics with documented efficacy. How long should probiotics be taken? And in our recommendation, we are usually saying throughout the antibiotic therapy. You also ask how should probiotics continue after antibiotics? And here's no consensus. However, in many clinical trials, probiotics were extended 7 to 14 days after antibiotic treatment. But I just want to clarify just one thing, because I mentioned that probiotics should be started as early as antibiotic therapy starts. But here it's important to remember that not all antibiotics are equally likely to cause antibiotic-associated diarrhea. In pediatrics, we are often using amoxicillin with clavulanate, cephalosporins. So those are antibiotics when this risk is relatively high. But when we're using penicillin, for example, this risk of AAD is not so high. So the use of probiotics, even with documented efficacy, is not a must.
Okay. I think some of the audiences may be neonatologists. So I would like to ask about the premature infants. So what is the current evidence on using probiotics during their early postnatal period, especially the preemies?
Yeah, that's a most difficult question, I should say, because there's a lot of discussion about the use of probiotics in preterm infants particularly for prevention of necrotizing enterocolitis. And in guidelines, there are certain conditional recommendation for the use of certain strains, like, for example, L. rhamnosus GG, or the combination of 3 strains, Bifidobacterium infantis BB02, Bifidobacterium lactis BB12, and Streptococcus thermophilus TH4. When I'm saying there is a lot of discussion about the use of probiotics in preterm infants, it is because of the safety concerns. And we know we are living live microorganisms. There is always a risk of sepsis. So this is one of the issues that is being discussed. An approach in different parts of the world may be different. In Europe, I think we are more probiotic use. In the United States, there's many concerns. There is none of the product which is registered as a drug. So there is some discussion. However, on the other hand, at least within the FISPGHAN, we made it absolutely clear that probiotic sepsis, whether it's a product has a pharmaceutical grade quality or it's a food supplement registered as a food supplement, the risk of probiotic sepsis remains, because we are dealing with the live microorganism, and probiotic sepsis may be caused by factors which are unrelated to product quality, such as, for example, intestinal translocation. So this is a difficult question, different approaches in different parts of the world, but we do have some strains with a positive recommendation.
Thank you very much, Professor Hania, for the great perspective on the probiotic use. Hopefully we have many more time. Hopefully next session we can ask you more about probiotics. So thank you, Professor. For more information, please refer to the following societal paper given in this video clip, and please stay tuned for the next FISPGHAN Expert Insights. Goodbye for now.
Thanks a lot.